everyone, welcome to BottledUp. Today we're gonna learn diabetes insipidus. Usually, patients are said to be diabetic when they have high blood sugars, but that diabetes is diabetes mellitus. Diabetes insipidus is not same as diabetes mellitus. The blood sugar levels are normal, but the kidneys can't concentrate the urine properly. DI can be due to inability to concentrate the urine due to lack of ADH, known as central DI, or it could be due to the inability to concentrate the urine due to failure of kidneys' response to circulating ADH, called as nephrogenic DI. So, patients will be having ADH resistance. So, what is ADH? ADH stands for antidiuretic hormone, also known as vasopressin. It is a hormone from the posterior pituitary. Another hormone from the posterior pituitary is oxytocin. ADH is released as precursor polypeptide from the hypothalamus, composed of AVP, which is arginine vasopressin, neurophysin, and copeptin. The picture here shows hypothalamus, pituitary stalk, anterior pituitary, and the posterior pituitary. The precursor polypeptides AVP, neurophysin, and copeptin from the hypothalamus through the pituitary stalk reaches the posterior pituitary, and it is released as ADH from the posterior pituitary. Other hormone released from the posterior pituitary is the oxytocin. ADH acts on three different receptors: V1, V2, V3 or V1b receptor. V1 receptor is present on blood vessels. It causes a pressure effect leading to vasoconstriction. V2 receptors are found on the renal vascular endothelium. V3 or V1b receptor is found in the pituitary. So when ADH acts on the V3 receptor, there is increased production of ACTH. What are the stimuli for ADH production? Glucocorticoid deficiency, nausea, acute hypoglycemia, and dehydration. When patient is dehydrated, ADH level increases and patient feels thirst. ADH acts on the collecting duct of nephrons. This is a picture of a nephron. A nephron consists of Bowman's capsule, PCT, loop of Henle, DCT, and collecting duct. So ADH acts on the collecting duct. ADH in blood acts on V2 receptor. V2 receptor is found on basolateral membrane of cell of collecting duct. So when ADH binds to V2 receptor, it causes mobilization of aquaporin 2. So aquaporin 2 now goes and sits on the luminal membrane. The water in urine now travels into the cell, and then this water travels into blood through aquaporin 3 and 4 channels. So where is aquaporin 1? It is located on the cells of PCT, and ADH does not have an action on aquaporin 1. Aquaporin 1 is present on PCT. Now let's get back to the different types of DI. DI is of two types, central and nephrogenic. Central DI occurs if there is pituitary tumor, which may be a primary tumor or could be due to metastasis. If there is any damage to the pituitary due to trauma, surgery, the causes of central DI are pituitary tumors, which may be primary or metastasis from elsewhere, then trauma, surgery, ischemic encephalopathy, autosomal dominant inheritance, idiopathic infections like meningitis encephalitis, inflammations like vaginous granulomatosis, lupus disease, toxins like snake venom, These are few causes. So, in central DI, pituitary is affected and there is low serum ADH levels. What are the causes of nephrogenic DI? The main cause is ADH receptor mutation, or it could be secondary to hypercalcemia, cancers, sarcoidosis, urethric obstruction, amyloidosis, vascular in origin like sickle cell, acute tubular necrosis, or it could be secondary to certain drugs like lithium, methoxyfluorine, rifampicin, foscarnet, aminoglycosides, amphotericin B, cisplatin, limiclocytin, which is an ADH antagonist. Patients with nephrogenic DI have high serum ADH levels. In both DI, patient complains of excess urination. Patients with central DI have hypoactivity of the pituitary. So, ADH production is low to nil and urine doesn't get concentrated, leading to dilute excess urination. In nephrogenic DI, ADH is unable to act on its receptor. So, ADH level will be high in the serum, and since the function of ADH is not taking place, there is high quantity of urine. If there is excess urination, we should check the lab parameters. On checking, we can see that there is high serum osmolality and high serum sodium levels. In such cases, we should check urine osmolality. On checking urine osmolality, we can see that it could be either low or normal. If it is low, it could be DI or primary polydipsia. If it is normal, the patient may be having diabetes, or he is on mannitol, or is having hypercalcemia. What is primary polydipsia? Primary polydipsia means excess drinking of water. It could be due to a compulsion. The patient can be a compulsive drinker, or he may be drinking to maintain his health, or it could be dipsogenic, seen in patients with multiple sclerosis, TB, meningitis, sarcoidosis. What are the tests to differentiate DI from primary polydipsia? The main test is water deprivation test. We ask the patient to abstain from drinking water. If the urinary osmolality increases, patient has primary polydipsia. If there is no change in the urinary osmolality, then it is diabetes insipidus. So this is an easy way to remember what decreases and what increases in DI and primary polydipsia. In DI, since there is dilute urine, the urinary osmolality is low. In primary polydipsia also, due to excess intake of water, urinary osmolality will be low. In DI, since all the water is lost through urine, the serum osmolality increases. Whereas in primary polydipsia, since the patient keeps drinking water, the serum osmolality will remain low. In DI, since the serum is getting concentrated, serum sodium levels is found to be increased, whereas in primary polydipsia, it is seen to be low. To differentiate central and nephrogenic DI, we give ADH analog and then check the urine osmolality. If it is seen to be increasing, the patient has ADH deficiency, that is central DI. If there is no change, there could be ADH resistance, that is nephrogenic DI. Other tests to differentiate central from nephrogenic is serum ADH levels. If the serum ADH level is high, patient could be either having central DI or primary polydipsia. If it is low, patient could be having nephrogenic DI. So to differentiate this central DI from primary polydipsia, we should take an MRI and look for pituitary bright spot. If it is present, patient is said to have primary polydipsia. If it is absent, patient has central DI. Now let's get to the treatment options. For nephrogenic DI, we give thiazides, indomethacin, amloride, hydration, salt restriction, and we ask the patient to avoid the offending agent. How does thiazides work? Thiazides inhibit sodium reabsorption from the DCT. So urinary sodium level increases and urinary water loss increases. But the PCT here is normal, so sodium and water reabsorption will start to increase. Hence, less sodium and water reaches the DCT, leading to decrease in the urine output. And how do we treat central DI? To treat central DI, we give desmopressin, which is an ADH analog, and also hydration. So this is all about diabetes insipidus, and I hope you enjoyed the video. Thanks for watching, and please don't forget to subscribe to our channel.